The most important thing for your listeners to know is that the American Academy of Family Physicians recommends the 3-dose series of hepatitis B for all infants, and that first shot would be given shortly after birth, and that we know that this is critical to protect babies from potentially devastating disease with lifelong impacts.
Today, I'm speaking with Dr. Sarah Nosal, who is leading one of the most influential physician organizations in the U.S. And as many of you know, it's been a very turbulent time in healthcare, especially in 2025. If you're following the news, we're all seeing what's happening with the Affordable Care Act and the debate between the Democrats and Republicans, a lot of the sweeping changes at the FDA, CDC, and more. So I'm really excited today to talk to Dr. Sarah Nosal. Now, a little bit about Dr. Nosal. She's the president and serves on the board of directors of the American Academy of Family Physicians, representing more than 130,000 physicians and medical students. She's also the vice president for innovation and optimization and chief medical information officer at the Institute for Family Health, a health center network across New York. She's been serving patients in the South Bronx for over 20 years and has driven system-level improvements in data sharing, equitable information access, and IT infrastructure. And she's led the Institute's COVID-19 response, including telehealth expansion and vaccination operations. She's currently the assistant professor in the Mount Sinai Department of Family Medicine and Community Health, and has focused for a long time on really providing care for marginalized and uninsured populations. She's active in the Medical Society of the State of New York, where she co-chairs preventative medicine and family health efforts. Dr. Nosal earned her undergraduate degree from Bryn Mawr College and her MD from the Albert Einstein College of Medicine, and completed a residency in urban family practice at Beth Israel Medical Center and the Institute for Family Health. She's board certified in family medicine and holds the AAFP degree of fellow for distinguished service and continued professional development. Sarah, welcome to the podcast.
Thank you so much for having me.
Great pleasure to have you on here, and excited to talk to you about a lot of exciting things happening in healthcare today. So maybe we could start out by just kind of you maybe walk us through your background. What inspired you to get into medicine to begin with?
So I actually grew up outside Washington, D.C. During a pretty rough time in trickle-down economics in our country, and was really taken aback as a young child by the tremendous homelessness and people sleeping on the grates, particularly veterans, in our nation's capital, and had always thought how important our nation's capital was as sort of an example for the rest of the world, and couldn't understand what was happening there. And I knew I wanted to be a physician at a very young age, like even then. And my mom, who was a social worker, said I could be the kind of physician who could take care of those individuals who were suffering and not connected, to the rest of the system.
That's amazing. And so you grew up in the DC area?
I did. So I felt like my everyday life was definitely impacted by what was happening, in politics in our nation. And as I worked through high school and college, I ran our community service efforts both in our city, in our town, and then founded our community service office at my college, doing work in inner city Philadelphia and Kensington, working with welfare rights community groups and working with the Catholic Workers Free Clinic there, recognizing that that's how I'd want to spend the rest of my career, and looked for a medical school that was doing that work as well. And it turned out the year I was applying to medical school in 1999, Albert Einstein College of Medicine had founded the first student-run free clinic in New York State. And they were admitting people on a rolling basis. And I still had other interviews to go, but was admitted to Einstein and canceled all of my other med school interviews, determined to help run that free clinic. And I started working there my first year of medical school. And I was just meeting the new class that I'm supervising, who's running that free clinic earlier this week.
Wow, that's amazing. And how do you think medicine's changed maybe in the last 20 years, especially in the primary care setting?
So when I started med school, that's when CHIP, so for people who are familiar, the Children's Health Insurance program, that had just been passed a few years before I started medical school. And in that free clinic, I was working as a first year at the front desk. We used to see children because children didn't have insurance. They couldn't get vaccines or preventative care. And we had a certified enroller in the lobby because that was the first time it was possible to enroll people, young people, children in CHIP. That felt like such a tremendous change at the time. And now when I look back to think, wow, we could really do amazing work in healthcare. We can create access and prevention and good outcomes. So I think that it's so possible. And it also feels, particularly now, as we're dismantling so much of the important structure, so daunting.
That makes sense. And one of the things that we hear all the time in working with healthcare systems and pharmaceutical companies, we hear a lot about the burden of prior authorization. I know family doctors, are often described as like the backbone of the healthcare system, but I know also many of them that I've talked to feel burned out, especially from the administrative burden. I'm sure you probably know this, but prior authorization is the number one reason for care denial in the U.S. It really impacts care. What do you hear from your members?
So the American Academy of Family Physicians spends a ton of our efforts on advocacy work, like things like prior authorization. It's recognized, as you said, by our family docs as one of the most just unnecessary burdens that they're facing. And for your listeners who may be familiar, is they've probably had something that they couldn't get from a prior authorization. Most of the time, eventually, it's approved. So what we've really had is, I know you need an x-ray, or I know you need a particular medication. I order that. And your insurance says, oh, I know your doctor says you need that, but have you done 5 other things, which I may or may not have done because I actually know that's the right thing right away and I don't need to do wrong things first. Or I maybe did those 5 other things and actually because you paid the bill for them. And I have now spent hours, or my staff has spent hours, or cumulatively all of us have spent hours, that is not in actually caring for the patient, delaying care that we knew was appropriate, when the vast majority of the time that actually is going to be approved and move forward because it is recognized ultimately that it was the appropriate plan of care. So it's sort of both the time, effort, and that we can't sustainably afford to do that, and that it's just heartbreaking that we are spending time doing something that we know is going to end up with the same outcome regardless of the effort. That it is effort for effort's sake, not for actual help or support of the patient. And it's tedious for the physician who knows the right care.
Yeah, it's frustrating. And one of the things I was just talking about the other day was around obviously the development now of AI, and AI being used to facilitate things like prior authorization and other administrative things. I'm curious, given your background and data and infrastructure, how do you think AI is going to change things in 2026 for the primary care setting?
So family doctors are actually really pretty excited about AI. We did participate in both a large working group and have published a white paper that talks about how primary care and family docs are looking at and interested in approaching AI. I would tell you, for this particular circumstance where we're looking at prior authorizations, we don't need to have them. So yes, can I make AI do a better job? One, yes, I'm concerned that insurance companies can make it manipulate my information to tell me no, even if I have information there. What you're going to then ask me to do is invest financial resources that are unfunded to also have AI, to talk to your AI, to ultimately decide we can do that care again. So while I think that administrative tasks that don't require a physician, the rest of our healthcare team, those administrative tasks should be done and supported by AI, and they will be. There are also tasks that don't need to exist, and we shouldn't sustain them just because we can make AI participate in them.
And I have the similar concerns. I'm sure you saw a few months ago in the news, United Healthcare, they were being investigated for allegedly manipulating the AI algorithm to deny more claims. So from my standpoint, especially around prior authorization, I have some concerns about the quality checks that are in place. I do think, especially in more serious situations, it's important to have a human to check on what's happening there in terms of what's approved or denied. And so, that goes back obviously to policy. And speaking of policy, I'm curious, you represent, like I mentioned at the outset, over 130,000, members, physician members across the country. What do you think is the single biggest misconception that policymakers have about what primary care actually looks like today in 2025?
So family docs have been misrepresented repeatedly. When we ask the public how much money is going into primary care and family medicine, they think a large percentage, like 50%. They assume, because so much of their health relies on primary care, that that's how it's funded. And we are in the single digits. We're lucky when we get to 6 or 7%. And other countries so that are really having better health outcomes, when we look at those charts and we say, why are we spending so much money and not getting those good health outcomes? They're spending 12, 14, 15% of healthcare dollar. So if we're spending 7 cents on the dollar for primary care and patients and community members think we're spending 50 cents, you can see how we're not asking as a whole country for the right thing for our health, when we need to be more than doubling our investment in primary care. So I would say by far, how much we're actually investing is the biggest misconception, and where we need to be is the biggest place where family docs and the AAFP is working towards.
Do you think there's a primary care shortage in the country?
There's absolutely, if you ask anyone in your family who's tried to get a appointment with a new family physician, a primary care physician, they are really struggling to find them. I get to visit our chapters across our whole country, and I've had multiple states where the average wait time is 6 months to be set up with a new primary care physician. And that's places where they've prioritized primary care, where they're tracking this and looking and trying to get people into care. We absolutely now, and as people retire, as large swaths of baby boomers are going to leave the workforce, we are going to be in crisis and need to be investing in our family docs and primary care.
Yeah, and I would agree. I think it's a major issue. So tell the audience then, because I think you bring up a good point. When I talk to people, sometimes they're not clear on the difference between a physician who's an internal medicine physician versus a family physician. What's the difference?
The best part about being a family doctor is that I get to take care of babies, pregnant people, children, adolescents, as people as they get older. I'm also an HIV specialist. We get to do procedures in our office. So we're really taking care of all ages, all genders across the lifespan. And we are doing primary care. An internal medicine doctor may also be doing primary care. They are largely taking care of people 18 years and older. And so they often end up having as people get much older, have more complex medical problems, end up having a much older patient panel of people who are older adults with more complex medical care, where I have both those older adults with complex medical care to newborn babies and pregnant people that I'm taking care of from the start of their life. And I get to do that both continuously through their lifespan, and I get to take care of whole families. So I often will see great grandmom and a newborn great grandkid even in the same visit.
That's great. I love that. And I appreciate you making that distinction, because again, I think a lot of people aren't aware of that. I would imagine as a family doc, you get visited a lot by pharmaceutical companies. Is that right?
So I actually work for a network of federally qualified health centers, and that means we see all people regardless of their ability to pay. We also do not permit pharmaceutical companies to solicit. We are grateful for innovation in pharmaceuticals, of course, but we also know that both direct-to-consumer advertising or bringing information into our office might unduly influence physicians and patients to be choosing less effective, more expensive medications. And our goal is to really find the most effective, evidence-based, science-based treatments for our patients.
Wow. Okay. So you don't get any of the friendly farmer rep coming in and bringing lunch or anything like that. You don't do that. Do you find that a lot of now health systems or ACOs are moving in that direction, where they're saying, hey, look, we don't want to give access to pharmaceutical reps?
I think that there's overall an interest on the part of all healthcare organizations, particularly primary care and family medicine, to make sure that our choices of treatment are evidence-based and science-based, and that anything that could unduly influence that it has moved out more and more out of from the small office to the large organizations.
Yeah. And I'm happy you said that, because, for transparency, my background is I worked in the pharmaceutical industry for many years. And one of the things that we focus on in our organization now, the ACMA, is on raising the bar for pharmaceutical industry professionals that do go out and talk to doctors. And that's one of the reasons why, is because unfortunately, a lot of times the information that goes out is not evidence-based. It could be biased. It could, unfortunately impact physicians in an incorrect way. And on that note, you obviously, I'm sure, are aware, recently the U.S. Advisory Committee on Immunization Practices voted to remove the broad recommendation that newborns in the U.S. receive a Hep B vaccine. So I'm just curious, given what you do, what's your take on this, and maybe what's the AAFP's official position on this as well?
Yeah, the most important thing for your listeners to know is that the American Academy of Family Physicians recommends the 3-dose series of hepatitis B for all infants, and that first shot would be given shortly after birth. And that we know that this is critical to protect babies from potentially devastating disease with lifelong impacts. So that's the place where I start. There are intricacies in what the ACIP has recommended. So there are two pieces to sort of what the recommendations were. So right this moment, if I am delivering a baby and that baby is born, the next day we are going to be talking to parents and we're going to say, hey, this is what we recommend today. We would take you would get the hepatitis B vaccine. That has been the standard practice. We never give a vaccine to anyone in a family that hasn't been spoken to. But now they're saying that rather than giving that hepatitis B vaccine and just telling the parent that's what you recommend, that if the parent has been tested, the birthing parent has been tested during pregnancy for hepatitis B and tested negative, that the newborn would not be given the dose at birth. And that, in fact, you would wait until the newborn was 2 months old. You could still have a discussion with the family, but it is not now like the default recommendation is you would give that vaccine. So that's the first part of it. The second part, also not evidence-based or supported by the literature, is that you would then do blood testing, which is actually routinely not a recommendation actually for children in general to do antibody testing, to see if there is immunity after the first shot. But an antibody test, even if it were positive, does not tell you that you've established that lifelong immunity, which is really what we're looking for, sustained decades of immunity to hepatitis B. So that single vaccine and that test, those are the two components of this recommendation.
Got it. Why do you think they changed the recommendation?
I am concerned that we were not using, science or literature, and that there were other motivations to change a evidence-based, science-based recommendation that's been well established and we know has worked tremendously well at reducing what were previously, 18,000 children who had hepatitis B infections annually, and now has largely resolved. Hepatitis B is ever occurring in infancy with with routine vaccination.
Right. Yeah, because you would agree this is one of the biggest changes, I think, since this administration has taken over.
Yeah, it's heartbreaking.
Yeah. What's the relationship like, I guess, between AAFP and organizations like CDC, HHS, FDA? Do you guys collaborate? Do you talk? Talk to us a little bit about that. How does that work?
So the AAFP has a long history of collaborating with all of those organizations. We've really relied on wonderfully established, previously evidence-based, science-based federal, organizations to help collaborate, to guide our members and patients and families to be making evidence-based choices. There are still wonderful people working within those organizations who are doing strong evidence-based public health work. So I want to make sure that we acknowledge that we know there are scientists and researchers who are still within those organizations who care deeply about science and evidence-based care. And that also there are different motivations that are leading to non-evidence, non-science-based guidelines being pushed out at the top that are really a grave concern. We will continue to collaborate because we want to bring to the table guidance and support of science and evidence-based guidelines, but also know that at times that is not the direction of where leadership seems to be going.
One of the things that came out this year at the FDA, they put a new guidance that instead of requiring 2 pivotal clinical trials for approval, they're only going to require 1. So they're kind of, some could argue lowering the standard for pharma companies in terms of getting an approval. What are your thoughts on that?
I don't know that the AAFP has established an official position, except that we, in general, would like to see full appropriate study and oversight of any pharmaceuticals that come forward, that there's an expectation that many of the procedures that have been in place are in place because we have seen that with appropriate research, guidance, and supervision and reporting, as we see complications, even after things have entered the general public, which is often when we see more rare complications and side effects, we, in general, have been in support of maintaining the appropriate structures and oversight that have kept pharmaceuticals, vaccines safe for decades.
Like I mentioned, you're leading obviously a very important organization in the country. And again, it's a lot of changes happening in healthcare. What has surprised you the most about your role as president since you've taken, this position?
That's an interesting question. I would tell you lots of things have surprised me this past year. I think that this is really hard on the national level and in the exam room with my patient. I don't know that I would have had the same, like, this circumspect vision of how difficult this kind of misinformation, disinformation that's happening, that I have such a pulse on the national level, how hard that is for families when they come and see me in my office and don't know, because they've seen on TikTok and on the news and on, a chat group from their community that's telling them things that are scaring them about choices that they've made or are
Right.
planning to make for their family, and what that means for families that are both incredibly well educated and families who have language, third grade education and a second language, and how do they make the best choices, and how many more questions that means that I get in my office, and how I have to make time to make sure that I'm able to answer those questions and provide information in a way that my patients can understand so that they can make the best informed decisions for their family.
There's a lot of, misinformation, unfortunately, out there with social media. Where can patients go to get accurate information? What would you advise folks that are listening to this podcast and they're looking to get the right guidance on the vaccines and things, obviously outside of going to their doctor? I mean, where can they get appropriate information?
And I obviously would still start with their doctor, because your family doctor, your primary care doc, is going to know you best and your history, and know what things what you may need extra care or different care, or have an allergy that would change some recommendations. So that is the first place. We really love to share with our patients. familydoctor.org, which is our patient-facing website, has incredibly detailed but accessible information on the hepatitis B vaccine and the new guidelines and what you should talk about with your doctor. Has tons of information on how to be ready for cold and flu season and what you should be thinking about, how to control your diabetes, or how you want to be thinking about medications like, injectables for weight loss, and how do you make those choices? What questions should you bring to your doctor's appointment when you go in there to be able to have that conversation? And I think patients are really looking for that, and they want to have trusted sources. And it is much less clear what a trusted source is. So familydoctor.org, I know, is a trusted source for my patients.
You seem very optimistic, despite all the challenges in primary care, and I love that. What do you think keeps your optimism going and that positive, mindset?
So when you look at data and research about family medicine and primary care, we actually know that family docs will improve the lifespan of a community, they decrease the cost of care, and they improve the equitable receiving and acquisition of care within every community that you put a family doctor in. So we're at a crisis in that we don't have enough family docs and primary care docs to be in all of our communities, but that's a choice, and we can make a change there and make that happen. But we know that when we are there, we can absolutely impact, most economically of all types of doctors, the outcomes of that community. And so that has to bring me optimism, because I know that the work we do is so incredibly important and impactful.
Yeah, I could tell just, in speaking to you, one of the things that I really admire is I could see that the patient is really at the center of everything that you do. Just the arc of your journey from the beginning. I love that story in the beginning, when you saw those folks that were homeless and how that really drove you. And that's beautiful. Just, maybe if you want to leave the audience with some last words, and keeping in mind a lot of our audience are healthcare providers, many of our people that work in the pharmaceutical industry, what would you say to them that you think you really want them to know about just primary care medicine or about patients that they should keep top of mind?
So as family doctors, as physicians, as members of our healthcare team, including our pharmaceutical services that are critical to all the care of our patients, we need to be the trustworthy partners that our patients need right now, in a time where it's really unclear where to look for that relationship. And so the federal guidance is going to continue to change, and sometimes we will be in step with that, and sometimes it will be not credible, and we will have to challenge it with science and evidence-based medicine. But that we will continue to do that. The AAFP will do that for our members and for our patients, and be able to reinforce those recommendations that are science-based and evidence-based. And that when you have a question, when your patients have questions about vaccines, about health, that coming to your family doctor, coming into your primary care doc's office is where you want to be.
I agree. And I think this is one of the reasons why, especially in the last few years after COVID, and I think moving forward, credibility, having the right credentials, having the right compliance guardrails are so important. This is why I'm a big believer of making sure that the folks in the pharmaceutical industry that are providing education, providing information, sponsoring studies, have the right standards in place from a certification standpoint. Just the way, as a doctor, you have to be board certified. I'm a big believer. The people that are running these trials, they should have some type of minimum standard of competency, which it sounds like you agree with, and I think it's really, really important. So, Dr. Sarah Nosal, really happy to have you here on today's podcast. It was a great conversation. I enjoyed it and love to have you back. And thanks for all the work that you do.
Thanks so much.